Hello and welcome to the digital version of Mental Health Policy. Today we're going to be talking about the Affordable Care Act and its implications for mental health and substance abuse policy. So let's start with discussing the purposes of the Affordable Care Act and some basic outlines of the parameters of the policies implemented in the Affordable Care Act. The Affordable Care Act attempts to do a number of things, mostly related to insurance, health insurance. The first thing is to increase access to health insurance, and the Affordable Care Act does that through a number of policy mechanisms. First of all, it extended the length of time that young adults are able to stay on their parents' policies to 26. I believe the previous age was 21. It expands Medicaid to 133% of poverty from a varying set of poverty lines depending on the states. There are some states that have opted out of it, following a Supreme Court ruling, but we'll talk about that in more detail. It built federal and state health insurance exchanges, which allow for the marketplace to be developed for selling health insurance to individuals, and we'll talk in some detail about what that is. And then it provided subsidies to help individuals afford coverage in those same sets of marketplaces. There's also a pending Supreme Court case that we're going to talk about briefly that could potentially have some negative consequences for the subsidies associated with the insurance. So that's all about increasing access to health insurance. The second mechanism that the Affordable Care Act attempted to manipulate was what is covered under health insurance. So there were a wide variety of benefits packages available, and it tried to standardize some basic benefits packages. So there's certain things like substance abuse and mental health coverage, which are now mandated to be part of any insurance offering through the exchanges and also through Medicaid and Medicare. That also comes under this discussion of parity. And then it also increased a variety of consumer protections for individuals purchasing health insurance through both the marketplace, primarily through the exchanges and the insurance marketplace provided by the states, but also extends elsewhere in insurance coverage. There's a couple of other residual things. It did some stuff around experiments on payment mechanisms. We're going to talk a little bit about that today. In other classes, we're going to spend more time focused on those alternative forms of paying for health services, generally covered under the rubric of paying for quality, not quantity. And then there's some other stuff that's included in the Affordable Care Act. We're probably not going to talk about that today. The Affordable Care Act was passed and began in 2009 and began implementation in 2010. The increased coverage for kids was implemented in 2010, and most of the law has been implemented as of 2014. The state-based exchanges, Medicaid expansion, and a whole host of the rules for expanding what is covered under Medicaid were all completed in 2014. There's a few additional things that will continue to be implemented in 2016, and then another set of stuff 2018. But those are relatively minor provisions. For the most part, the bulk of the Affordable Care Act went into effect in 2014. There are several court cases that have modified the law. We'll talk briefly about what those are, and they primarily have currently affected Medicaid expansion, but there's a pending case that could affect subsidies. The Affordable Care Act was designed to affect the larger health insurance market, and that's for a whole host of people. The primary targets were individuals that were not covered by employee-based health insurance and were not covered either by Medicare or Medicaid, which cover folks over 65 or folks that have very low income, primarily below poverty. And a lot of people in that gap that were either several states, for example, did not cover any individuals, regardless of how poor they were, under Medicaid if they were single, childless adults. And often those were men with mental health problems. So individuals that were not eligible for Medicaid through Social Security or other disability payments were often not allowed to enroll in Medicaid, were not eligible in a given state, and because of that did not have health insurance coverage. So it's been estimated about 39% of the folks served by state mental health agencies have no health insurance. 39% of the folks served by state mental health agencies, which almost invariably have some medical necessity criteria, were not covered under health insurance. So for those individuals, the expansion of Medicaid or even subsidy-based exchanges are going to be very beneficial in terms of expanding access to coverage. Similarly, about 61% of the folks served by substance abuse agencies have no health insurance. So a lot of the folks that we talk about in this class in terms of mental health and substance abuse policies will be getting coverage through primarily Medicaid expansion, but also the state-based subsidies. The primary goal, as mentioned before, of the Affordable Care Act is to expand health insurance coverage. At the point of passage, it was estimated that about 83% of the U.S. population had health insurance, leaving about 16-17% of the population uninsured. Once the Affordable Care Act is fully implemented and everyone that is eligible has coverage, it's estimated that about 94% of the population will have coverage. So that's an increase of 11% of the population. So that's the primary target of the Affordable Care Act, is to address the problem of that 13% of the population that is not currently covered under either employee-based health insurance or Medicare, Medicaid, or other government programs or the private market. It does this through a set of tools. One, expanding the existing coverage through Medicaid. So all states that choose to accept the expanded Medicaid coverage will cover individuals up to 133% of the poverty level. And for a lot of states, before the Affordable Care Act was passed, they didn't have any coverage for single individuals. A lot of it was geared toward women and children. Some states had relatively strict poverty cutoff limits, so individuals that were above 50% of the poverty level weren't eligible. So again, it was a state-by-state thing, but all states that choose to expand Medicaid coverage will have 133% of poverty. Individuals below 133% of poverty will be eligible to enroll in state-based Medicaid. The federal government picks up the vast majority of the cost of that. I think it's 100% for the first 5 years and then 90% thereafter. It was estimated at the beginning that 34 to 50 million people would have coverage expanded under this option. So this is the primary mechanism, and certainly the primary mechanism for substance abuse and folks with mental health problems. Unfortunately, from the Medicaid point of view and for these people's point of view, the Supreme Court said that it was unconstitutional for the federal government to require states to expand Medicaid. And so states can either opt in or opt out, and about half the states at this point have elected to opt in. Of the remaining states, a number of them are continuing to negotiate with the federal government to develop specific plans that are acceptable to state legislatures and also to the federal government under the Affordable Care Act. So as we go through time, more and more states are going to opt into Medicaid expansion, but it's going to happen with a variety of different plans. For example, Arkansas recently passed their version of Medicaid expansion, but it enrolls people in the exchange-based programs in the private market as opposed to the public-based Medicaid. So there's a lot of experimenting going on, which is a benefit of federalism and potentially a benefit of the Affordable Care Act's Medicaid expansion, because we can see how costs differ across different forms of implementation, whether public programs are able to deliver the kinds of quality at a reasonable cost compared to private programs. So there's sort of a positive benefit of that. Currently, however, a number of states, such as Texas and Florida and other states in the South, have not passed Medicaid expansion. And for those states, there's a huge gap in coverage for individuals, some of the most vulnerable individuals, specifically individuals that have substance abuse and mental health problems. The second mechanism by which the Affordable Care Act expands coverage is by developing state-based insurance exchanges. So if we take a step back and just think about what health insurance is. So I work for the University of Maryland. I have health insurance through the University of Maryland. My family has health insurance through the University of Maryland. What the University of Maryland and the state of Maryland have done is purchased health insurance for the whole population of people working for them. That's called a pool. And they insure the pool rather than individuals. So even if I have had cancer and I come into the University of Maryland system and I begin in my employment here, I come with a certain amount of health risk. But nobody really thinks about that health risk of me individually. They think about the health risk of the total body of people coming into employment at the University of Maryland or the state of Maryland. And that pool is insurable. There's a relatively reasonable cost guesstimate for how much that pool is going to cost, and that cost is then split between all of the members of that pool, and that's where your premiums come from. Now, when an individual, before the Affordable Care Act, when an individual was going to enroll in private health insurance, they came as an individual, not as a pool. And that's a problem for individuals that had pre-existing health problems. So if I had had some form of cancer, for example, I would be basically uninsurable outside of either government insurance or employer-based insurance. I couldn't purchase private-based insurance because I came with my risk, and it would just be too expensive for me to be insured in the private market. So what the federal government did through the Affordable Care Act and offered states an opportunity to, some states elected to develop their own exchanges. Maryland, for example, did. Other states elected to let the federal government set up the exchange for them. What those exchanges do is they form a pool of all uninsured people. And this is one of the critical reasons why you have to have a set of things that are included in the Affordable Care Act in order to compel people to purchase into that pool. Because if the pool of uninsured individuals, if the only people that buy out of that pool are sick people, who obviously want health insurance because they have some health problem and that is going to help them pay for it, you get what's known as a spiral of death, where the pool becomes sicker, and as it becomes sicker, it becomes more expensive because the premiums are just the total cost of the pool divided by each person. And as the pool becomes sicker and more expensive, only sicker people stay in the pool because they're the only people that it's cost effective for, and then you keep weeding people out, and that's called the spiral of death, resulting in insurance that's too expensive. To address the spiral of death problem, the Affordable Care Act has a mandate that is essentially a tax on individuals that elect not to enroll in health insurance. And the idea here is to get young, healthy people into the insurance pool to spread those costs. The idea being young, healthy people will soon be older, less healthy people, and so we all pay into the system, and as such, we're able to have reasonably inexpensive health care. And so that's why the mandate is such an essential component of health insurance. However, even with that, even with the expanded pool of private-based health insurance through the state-based exchanges, many individuals would not be able to afford health insurance coverage through those exchanges. And in order to facilitate those individuals being able to purchase private-based insurance through the state-based exchanges, there's a set of subsidies that the federal government is going to provide through, again, the tax code through the IRS. So individuals under 400% of poverty, which is about $72,000 for a family of four, will be eligible for subsidies to help pay the cost of that private-based health insurance. So the primary mechanism of expansion for individuals with substance abuse and mental health problems is the Medicaid expansion up to 133% of poverty. For individuals at 133% of poverty all the way up to 400% of poverty, there's the state-based exchanges with subsidized care. For individuals above 400% of poverty, there's still the state-based exchanges with all of the benefits that we're going to talk about in terms of expanded coverage, types of coverage and consumer protections, but they don't receive subsidies. So for the bulk of people, they fit within that 400% of poverty range, and so that's the primary target outside of Medicaid. It's estimated that about 25 million people will access health insurance through the state-based exchanges. So again, smaller than the Medicaid expansion, but still a sizable chunk of individuals. So there's a few other nuances to the Medicaid expansion. Between 2014 and 2016, the federal government pays 100%. Over time, that scales down to 90% at 2019, but still stays at 90%. So the federal government is going to pay for the vast majority of Medicaid expansion. States are only on the hook for about 10% of that expanded Medicaid group. Now remember, individuals that are currently going to be covered under Medicaid expansion would not have not gone to the hospital in the old system. there was a mechanism for compensating hospitals for uninsured-based care, and a lot of the funding for this comes through cutting those funds because now individuals would ostensibly be covered through Medicaid. Now, this obviously presents a problem for states that have elected not to enroll in Medicaid expansion because they no longer get the funds to cover the uninsured care, but they're also not getting those individuals into their Medicaid program. And that's a lot of what the pressure that's driving some of these Republican-based state legislatures that have historically been resistant to expanding Medicaid to think of alternative options and negotiate with the federal government around what kinds of care they feel comfortable providing for their state. Medicaid also was required to have parity between mental health and somatic health, and we've talked about that in a variety of mechanisms. Some state benefit plans included substance abuse and various packages for mental health, but now they have to have parity between the somatic offerings and the mental health and behavioral health offerings. There's a variety of home and community-based services that were also expanded, and then coverage was extended for foster kids to an older age. I believe it's 26 years old, just like with adults being covered on their parents' program. So there are a number of additional changes to other than the expansion in terms of Medicaid. The state-based exchanges, again, are either state or federal government set up healthcare pools that are community pools of individuals that collectively purchase health insurance. Individuals are required to have health insurance, which is the mandate through the Affordable Care Act. The penalty is a tax-based penalty. It's called a fee, or it's called a penalty, not a tax, but technically it's a tax for individuals that elect not to enroll in a health insurance plan. And the purpose is to encourage people to enroll in plans in order to prevent that spiral of death that we talked about, where only sick people enroll in coverage. And when we talk about consumer protections, we'll see the other side of this, and I'll come back and explain how the consumer protections and the exchanges have to work together. Coverage, the insurance provided through the state-based exchanges is private insurance. So it's not public insurance, it's private insurance. Individual private companies, the same companies that provide health insurance to employers, set up insurance plans. And they do so under a tiered system from bronze, silver, gold, and platinum. Platinum would be the most expensive up front, but would have the least costs after that. So co-pays and other forms of coinsurance would be lower under the platinum plan, but you'd pay more up front relative to a bronze plan where you would pay less up front but have more co-pays and other forms of payment that happen as you access care. So following the Affordable Care Act, the layers of insurance coverage in the United States are government-funded insurance programs, so that would be Medicare, Medicaid, VA, and other military programs, government insurance provided to employees of the government. Private-based, employer-based health insurance, so anybody that gets their insurance through their employer. And then state-based exchanges, private market, where individuals purchase health insurance through these state-based exchange mechanisms, up to 400% of poverty getting subsidies, individuals above 400% of poverty having access to the market but not receiving any subsidies. So that's the basic system we have for health insurance following the passage and implementation of the Affordable Care Act. So in addition to expanding coverage through these mechanisms, the Affordable Care Act also instituted a number of consumer protections that are designed to improve the insurance that individuals get and to limit the degree to which insurance companies can discriminate against individuals that are sick. So the first and probably most important element, and this goes back to the mandate, is that insurers can no longer deny coverage for individuals with pre-existing conditions. In the old market, before the Affordable Care Act, if you were an individual going to purchase health insurance through the private market outside of an employer, you would then have to submit to a health exam, and make all of your health records accessible to the insurance company. And the insurance company could look through and say, I see that you've been treated for depression before. That's a pre-existing condition. That's going to increase your costs, and they would have some actuarial number that increased the cost of. So you functioned as your own pool. Obviously, for individuals that had some serious health problem or mental health problem, insurance would become too expensive too quickly, and so they wouldn't be able to access it. So to prevent insurance companies from doing that, the Affordable Care Act does two things. One, it denies the use of pre-existing conditions as a reason to exclude people from health insurance or to price discriminate against them. But the second piece of it is it requires individuals to purchase health insurance. Now here's why the mandate and the pre-existing conditions clause go together. Let's think about auto insurance. If you could get auto insurance after you got into an accident, you would never get auto insurance before you would get into an accident. You would only purchase auto insurance for a limited period of time to cover the accident that had already happened, fix your car, and then stop getting the insurance. Now, from an insurance company's point of view, that's like everybody that comes to you is getting their car fixed, and there's not enough money in the system in order to pay for it. That would be a spiral of death. In health insurance, it works a similar way. If the pool of individuals that are purchasing insurance are too sick, the cost of insurance goes up. Now, if you're a 25-year-old and you're healthy and you look at the cost of a bronze plan and you say, that's way too expensive for me, it's not worth it because I haven't consumed health care in 4 or 5 years, I don't want to pay a couple $100s a month for my health insurance plan, then you're not going to enroll in health insurance. But if you're somebody that has, say, diabetes or some chronic expensive health condition that requires insulin or other medications, you would then be the person that would want to have health insurance to lower your costs. But if the only people in the insurance pool are people that have high health costs, then the premiums are going to be too high, and then you're going to get only sicker and sicker and sicker people for whom it is financially advantageous to purchase health insurance. And again, that's the spiral of death. The mandate is the mechanism by which that is countered. So insurers can no longer deny coverage for pre-existing conditions. They can't cancel your policy if you get sick and you haven't committed fraud. There are no lifetime caps allowed anymore. You have the right to an external appeal process to decide whether what you want to get in terms of a service is a benefit or should have been a benefit. Again, children can stay on their parents' insurance to 26, and you can use the closest ER without penalty. Further included in this package of expanding the types of coverage are things that we've talked about before in this class. Parity, for example, is an essential component of the Affordable Care Act. It expands mental health and substance abuse coverage to all states that choose to expand Medicaid. All policies offered through the exchange have to include an essential benefits package. Those essential benefits packages include mental health and substance abuse, and private insurers that elect to cover any mental health or substance abuse must do so with parity with somatic health. So care coordination is this idea that individuals that have very complex health needs, people that have CPOD, which is, we used to call it emphysema, so problems breathing, diabetes, other heart disease, high blood pressure, these chronic care conditions, which include substance abuse and mental health conditions, sometimes need higher levels of coordination between specialists and primary care providers in order to optimize health. The difficulty in the past has been these were fragmented systems. You would go see your primary care provider over here, which would provide a set of prescriptions. You'd see your specialty providers over here, and those specialty providers and the primary care provider wouldn't be on the same electronic medical record, wouldn't have any real form of communication to coordinate between the providers in terms of medications or treatment plans or anything like that, because the system was fragmented and based on this fee-for-service notion that you pay for each fee, which provides no mechanism for the provider to coordinate care. Care coordination costs money, and providers were only being paid based on the services they provide, so they had no incentive to coordinate. There are a few mechanisms that the Affordable Care Act uses to increase care coordination. One is healthcare homes. We'll talk about what that means. Another is accountable care organizations. We'll talk about what that means. They're slightly different, but both forms of modifying this fee-for-service system where you pay for each service you receive to paying for a package of services by a package of providers. So medical homes are a variety of different things, but we are seeing them particularly in the state of Maryland in the form of healthcare homes. In mental health, they're provided through PRPs, psychiatric rehabilitation facilities. And the idea is that these psychiatric rehabilitation facilities will have an on-staff medical provider that will be the point of coordination between mental health services, psychiatric and other mental health services, and primary care services. So the idea is that you have this single point around which all of the other providers communicate, and this central point, which is primarily a nurse practitioner or a nurse, will then have responsibility for making sure the care is all coordinated. And that's being implemented here in Maryland, and there's a number of other initiatives nationwide to expand this form of care coordination. These are primarily funded through grants to pay for the care coordination. And this essentially is the old brokerage model that we used to use in social work, where an individual case manager would provide brokerage coverage and attempt to hook individuals into all of the forms of care that they need. So it's a similar kind of model. Another mechanism by which the Affordable Care Act is expanding care coordination is occurring primarily through Medicare, but in the future will probably expand, given success, although the success is sort of questionable at this point, to other forms of health providers. So the idea behind an accountable care organization is that you have a network of providers that receive financial incentives to take on some of the risk associated with individuals' healthcare costs. And when I say risk, I mean money. So the idea is that instead of me going to a provider and paying that provider for a service, I would come, enrollment in an accountable care organization would come with a certain amount of money, regardless of what services I receive. So if I receive a lot of services, I will lose the accountable care organization money. If I receive fewer services, I will then save the accountable care organization money. And the model is that this form of insurance, where the accountable care organization is essentially taking a pool of risk, so each person comes with a certain amount of risk, and they come with a certain amount of dollars, and the idea is to match up those dollars with risk. But once an organization has full cost engagement with a person, then they have incentives to do lots of preventative care. So if I save money by preventing your substance abuse problem from escalating and you getting hospitalized or getting into an auto accident or you getting liver disease or you getting HIV, then I would save money through that form of prevention. So I have an incentive to talk to you about smoking, drinking. I have an incentive to provide a social worker on site that can do clinical care for substance abuse or mental health problems. Depression is a huge cost driver for other health costs. And so the idea being that as organizations take on your whole health as a risk, they will have an incentive to invest in your health and not just provide more services, because that's how they make money. They make money by preventing you from accessing more complicated and expensive health services. So the idea is to substitute cheaper prevention services for more expensive acute care services like hospitalization. So there's a real strong incentive to keep people out of the hospital and to engage in other forms of preventive activities to reduce the costs associated with an individual's health care. There are organizations that essentially function like this. So, for example, Kaiser Permanente, if you're a member of Kaiser Permanente, there's another one called Intermountain Health that's in Colorado. These are essentially organizations where all of the providers work for the organization. So Kaiser has a Kaiser Insurance Group and a Kaiser Provider Group, but they are totally linked. They're 100% linked. Kaiser Insurance contracts almost exclusively with the Kaiser providers. So if you have Kaiser, you go to a Kaiser hospital, you go to a Kaiser doctor. If you want to see a specialist, you're referred to a Kaiser specialist. So if you cost a lot of money, you cost Kaiser a lot of money. If you cost a little money, you save Kaiser a lot of money. So Kaiser has an incentive to engage in a lot of prevention activity to prevent you from having more expensive or escalating healthcare costs. So you'll see a lot more care coordination. You'll see a lot more use of nurses having regular contact with people, making sure they're taking their medication. There's some really interesting things Kaiser has been doing with computer-aided mental health coverage for people with depression or bipolar disease to help folks stay on their medication, stay in contact with their provider through email or chat mechanisms. They have regular contact with nurses that reach out and call people. So these are things that aren't cost effective when you're selling services on a fee-for-service basis. But when you have total cost accountability and risk with individuals, that's when these forms of care coordination become cost effective, because Kaiser either benefits or loses depending on how many services you receive. And they want you to receive high quality, low cost services, which are often the very same services that we want to provide, sort of the outpatient, the preventative services, rather than expensive hospitalizations and inpatient services. So the mechanism that the Accountable Care Act has implemented in order to share risk through these accountable care organizations, and again, this is primarily through Medicaid. We're soon going to hear some results of this initial phase of the experiment, and the reports that I'm hearing currently are that there are some evidences of success and some evidences of not really saving any money. But these are hard things to do, and hopefully over time we can get better at them. But the current mechanism is that an organization, an accountable care organization, can choose one of two tracks, track 1 or track 2, and they're differentiated on how much risk the organization is willing to take. The more risk you're willing to take, the more benefit you can potentially get. So track 1 is that any savings from what would have usually been spent for that person, usually spent as sort of an average expenditure per person kind of metric, that so track 1 is that any savings from what would have usually been spent for a set of patients will be shared 50%, 50-50 between the government and the private provider, and there's a minimum of 2% savings rate. So if you have to save more than 2%, but if you save, for example, 4%, you as an organization would get 2 of that percent, and the federal government would get 2% of that savings. So you would split the savings between the federal government and between the payer, which is primarily the federal government, and the provider organization. But there's no downside risk. You don't have any. If you cost more money, you don't lose any money. The second track is that you get, as a provider, you would get 60% of the savings, but you will also have to take on some of the loss. So if you take the 60-40 split, you have risk that you're going to take a loss. If you have a 50-50 split, you have no risk of downside. So it's a question of how much an organization was willing to gamble with their ability to reduce costs over the long term, or over I think this is an annual basis. Now, most of what I've been reading about the lack of success of the Affordable Care Act is that too many organizations selected track 1, and there's not enough risk involved to get them to try innovative strategies for reducing healthcare costs. So I think as we move forward, we're probably going to see more encouragement of risk. And as we get more experience with this, we're probably going to also see some payment systems shifting to this permanently and not offering people an opportunity to opt in, but rather requiring providers to work in groups like this. Another mechanism by which the Affordable Care Act is encouraging care coordination and improved forms of care that are relevant to mental health and social work in particular is through punishing hospitals that have too high a rate of readmission to the hospital. So hospitals have to take on some of the costs for that readmission, in some cases full costs for readmission following a discharge from the hospital. The idea being that a lot of people come back to the hospital because of poor discharge planning. There's no follow-up care, and hospitals, of course, have no incentive to provide care to people once they've left the hospital, because if you come back to the hospital under the old fee-for-service system, you just spend more money in the hospital. That's like saying a hotel doesn't want you to come back as a guest. Of course the hospitals wanted you to come back. In fact, their financial incentive was for you to come back. Now, most hospitals obviously want to provide high quality care and don't want repeat visits for poor quality care, but they certainly had no incentive to provide high quality discharge services and follow-up services to people that left the hospital. Now, this is a particular problem for mental health, where a lot of the folks that come in for care are marginally housed or have other social disadvantages, poor social support networks. These are exactly the kinds of people that are at risk for readmission at population levels, and we know that there's a lot of chronic readmission to the hospital in substance abuse and in mental health. And so having more aggressive care coordination and discharge planning, or even funding services like lower step-down level services, residential treatment beds or residential crisis beds, are the kinds of things that will become more palatable to hospitals when they're on the hook financially for any readmissions that happen following discharge. So the idea is to place costs on hospitals for poor discharge planning and poor follow-up, encouraging them to continue the care back into the community to prevent people from being hospitalized. So a lot of what we've been talking about are the statutory requirements as passed in 2009 in the Affordable Care Act, but there's been a number of changes to the legislation following Supreme Court cases. So the most important case is the Iran Supreme Court decision, which was a 5-4 decision that had a number of elements. First, it said that the mandate is constitutional. It's a power of Congress to tax. The mandate is essentially, it is a tax. Not calling it a tax, calling it a mandate was a political issue, but it functions like a tax. You get charged for not having health insurance, and that's taxing people. So the mandate is considered a tax under this Supreme Court decision. But they also found that Medicaid expansion violates Congress's spending clause power, as it's unconstitutionally coercive of the states. And so, because there are some state funds that will have to be involved, and Congress can't mandate that states fund things. And by mandated expansion, they were mandating that states take on additional funds. So what has happened is a number of states have elected not to expand Medicaid, primarily in the Mountain West and in the South. But some states have started to come on board. For example, I mentioned that Arkansas recently passed Medicaid expansion, but didn't do Medicaid expansion. They did expansion of the exchanges to that group of people that were above the Medicaid cutoff, the previous Medicaid poverty line, but below 133% of poverty. So they used the money from the federal government to help those folks buy private insurance. Indiana just passed a similar form of Medicaid expansion. So I think we're going to see some innovation around Medicaid, to get around this problem where states don't want to expand Medicaid, but they still want to expand insurance coverage for that gap of individuals above the current Medicaid cutoff line and 133% of poverty. There's an upcoming decision called the King decision, which is a little bit weird, and I'm not exactly it's a little bit odd to explain. Basically, there was either, depending on which side of the case you fall on, either an error in the way the law was written or an intent of Congress to deny subsidies to states that didn't set up their own exchanges. And the way the wording works, it's a little hard to figure out what Congress meant. Opponents of the Affordable Care Act want to say that states that chose not to set up their exchanges aren't eligible for subsidies. For those states, the federal government set up the exchanges. So it's a little unclear how that's going to work out, but that's currently being heard by the Supreme Court, and we're going to be hearing stuff about that really soon. I'll provide some links to some articles about that if you want more information.